was 20 years ago when I was a resident, for example. And so we asked the two of the best educators that we know in diabetes to put this talk together, and was delighted that they both accepted. So today, you are going to hear Navigating Treatment Algorithms for Type 2 Diabetes, a case-based approach, presented by Patrick Bowen, who is the section head at the Emory Clinic for diabetes, and Guillermo Umpierrez, who's the section chief at Grady, both of whom are recognized educators, phenomenal clinicians. So I will turn it over to you guys.
Thank you, Wendy, and thanks to everybody who's not yet on Thanksgiving vacation. For those of you, if you came expecting a debate today, unfortunately that was fake news. We considered that, and then Guillermo and I realized that basically we agree on everything when it comes to diabetes. That would have been the most boring debate of history. What we really asked to do, again, was to come up with something that was a little different format than the usual didactic Grand Rounds lecture that was focused on treatment of diabetes. And so what we're going to do, first of all, these are Guillermo's disclaimers and disclosures. I have none. I'm pure as the driven snow. So what we're going to do is briefly go over some of the complex physiology of type 2 diabetes, the fact that it's a progressive disease, and the myriad of treatment options that have been developed to lower glucose. Then introduce the algorithms that have been developed from our two major national organizations, the ADA and the American Association of Clinical Endocrinology. And then go through back and forth a series of cases that help navigate through those algorithms to make decisions in patients that present with different characteristics, with different comorbidities, and figure out which drug to use when and why. Have to start with the doomsday slide here of the global epidemic of diabetes. Clearly, we have a problem in the United States that's going to be supplanted by the disaster that's happening in South Asia and China. These are big numbers. We spend a ton of money on healthcare in this country in general, and this is looking at healthcare spending from 1996 and 2013. The largest absolute increase in health-related spending was for diabetes care. We're talking about $64 billion here increase over that period of time. And we are spending it primarily on drugs. So it's good to know what drugs are there and how best to use them. The good news is we're having an impact in reducing risk of complications of diabetes. This is data looking back from the 1990s to 2010. We're having a major impact in reducing primarily macrovascular complications here, cardiovascular disease, stroke, and amputation. Unfortunately, less of a decrease here with regard to microvascular complication of nephropathy, and fewer patients dying directly from hyperglycemia. So that's the good news. Type 2 diabetes definitely has complex pathophysiology involving multiple organ systems. When I was growing up, type 2 diabetes was insulin deficiency and insulin resistance at fat and muscle cells primarily. But what we've learned in the interim is that there's other things going on, abnormalities in signaling between the intestine and the pancreas through the incretin system, abnormal glucose handling at the level of the kidney, CNS effects that affect glucose homeostasis, and paradoxical increases in hepatic glucose production and glucagon production from the alpha cells, all of which contribute to hyperglycemia. The good news about this complex pathophysiology is it provides a lot of different targets for drug development. Got to emphasize that type 2 diabetes is not a static disease, it's a progressive disease. And with increasing duration of diabetes, the insulin resistance component continues relentlessly. And over time, the beta cells decline in their function. And this results in progressive hyperglycemia with increasing duration of diabetes and need for adding and intensification of therapy to try to keep the sugars in the target range. I think we're all familiar with the traditional ADA mantra of A1C less than 7. That's still in existence, but in the last couple years in their guidelines, they put an asterisk next to that A1C target of less than 7%, saying that actual A1C targets should be individualized in certain patients, particularly to avoid risk of hypoglycemia or in patients where a tight target may not be beneficial for their overall health. American Association of Clinical Endocrinology has typically had tighter glucose targets, and they actually are aiming for an A1C of less than or equal to 6.5% in most patients, but also allow for individualization of that glucose target in patients with concurrent serious illness or who are at risk for hypoglycemia. We have no less than 12, that's 1 dozen different classes of oral and injectable therapies that can be used in managing type 2 diabetes. Some of these are aimed at improving beta cell function, others improving insulin resistance at the level of the fat cell or at the level of the liver, ones that target the kidney and promote glycosuria, one that actually works in the CNS to try to improve glucose homeostasis there, ones that are working on handling of glucose in the gut, and those that try to augment the incretin system to improve insulin production and insulin action. And then, of course, there's always insulin that many patients with type 2 diabetes will end up on at some point. So what's a doc to do with 12 options? Well, if we're thinking about what the ideal therapy for type 2 diabetes would be, clearly it would be a drug that works in lowering glucose. It would be one that avoids risk of hypoglycemia, that's well tolerated, that tends to be weight-friendly, that has proven effects in reducing long-term complications of diabetes, that's cheap, and that patients will actually take. I listed patient preference and adherence last, but this is a really important thing to consider. Anybody who's watched the nightly news knows that about 3/4 of the commercials are for drugs, and the other quarter are for lawyers who are outlining the adverse effects of these drugs. And diabetes drugs are certainly commonly prescribed and a target for these. So patients are aware of these concerns about safety of diabetes medications, and if you don't address them and explain them, then that's a prescription that's not going to be filled or not picked up or not taken. So here is the current American Diabetes Association algorithm to help providers in terms of what to use when. And you can imagine, with 12 options of drugs, these are going to be complex algorithms. The ADA algorithm is based on the premise that you're going to decide on initial therapy based on how high the A1C is at presentation, and that unless the A1C is above 9% or 10%, then the recommendation for initial therapy is metformin in the absence of a contraindication or a tolerability issue. We love metformin. It's effective. It doesn't cause hypoglycemia generally as monotherapy, weight-friendly, and cheap as can be. The premise of this algorithm also is that if you're not achieving your glycemic target after 3 months of maximum tolerated or maximum dose metformin, you need to intensify and go to 2 drugs. Now, the ADA algorithm lists several options of drugs here, but it does not necessarily prioritize these. It gives you the option of choosing any of these, outlines some of their characteristics, but lets you make a choice. If you're not at target after 3 months on dual therapy, you add a 3rd drug or injectable therapy. The ACE algorithm is set up with the same premise in terms of intensification of therapy if your sugars aren't at target, but it has a lower threshold, first of all, in terms of initiating therapy or intensifying therapy. And it also presents more of a hierarchy of drug options at each point of this algorithm. So these are individual lines. Green is obviously good, and the length of the line suggests the strength of the recommendation of drugs to be used in sequence here. Yellow outlines certain cautions. This is a comprehensive algorithm that pretty much includes every drug that's FDA approved at this point, including ones that aren't very commonly prescribed. And again, it says intensify if you're not at the target. So you're going to be seeing these algorithms going forward in other slides, but I wanted to introduce them first. So we're going to move now to individual cases to help walk through those algorithms and pass back and forth. Guillermo is going to start with the first case.
Thank you, Patrick. So we put together very simple cases just to make the point, and kind of we can discuss the rationale of using a particular therapy. So you have somebody, 53, worked for Delta, diabetes for 5 years, did very well when the patient was started on metformin. His hypertension and hyperlipidemia is being well treated. They have no end-organ complication, and he is overweight, obese, like most of the patients with diabetes with a BMI of 31. Blood sugar is 150, 200. Hemoglobin A1C is 7.8. This is about half of the patients that we see in the clinic. So the question is, he's failing control. What do you do next? So first, let me tell you, but you have to keep in mind that if you start one single therapy, it could be metformin, sulfonylureas, whatever, it's going to fail. For example, this is studies that is called the United Kingdom Prospective Diabetes Studies. Patients treated with metformin as a single agent. If you, at 3 years, less than half have good control. These patients have 5 years of diabetes, so about 34%. And the reason why people fail is not that they don't follow maybe they don't follow, they're not the adherence, that is the beta cells of the pancreas. The disease itself is characterized but a progressive decline of the beta cells. They are autopsy serious. If you look at the pancreas of people who have died for a car accident, if they have pre-diabetes and diabetes, they have significant reduction of beta cells. So these patients are likely to require 2 or 3 agents. So the rule number 1 in diabetes care, if somebody fails to one agent, you don't substitute for a second agent. You add on. So that's the rule. So if you have patients, for example, here on metformin, and you switch them to sulfonylurea, nothing happens. The same thing, you can have a patient with sulfonylurea. As you put them on metformin, same hemoglobin A1C. The combination does a dramatic effects because they have different mechanism of action. So this is what Patrick already says. We start on metformin. It's cheap, less than $5. It works, and it has 30 or 40 years of experience. And there is no other drugs that have a better profile than metformin. In general, if you take cost, side effects, access for most of your patients. And if you fail, you can choose whatever you want. So, and then you combine and you do triple therapy. This is extremely confusing. That's right. I mean, how do you do that? Patrick already said there are 12 different agents. So which ones do you use? First, all of them work. So you can add to metformin whatever you want. But we have been working with the Diabetes Council with Bill Bernstein and many people in internal medicine and trying to put an algorithm to support our primary care through the Emory system. So this is what we are recommending. You should look at, if you start on monotherapy, metformin, you do dual therapies at 3 months, you are not on call, or not at call, and then you divide the patient where they are. So you have low budget. Well, we have now medications. They are generics. Do we have, for obese patients, we're going to use medication that produce weight loss. We're going to go in more detail of this. If you have a patient with established cardiovascular disease, we already have medications that have shown to reduce cardiovascular events in patients with diabetes. You have medications that you have to be concerned with kidney failures, and we're going to discuss this of the elderly person. So this was published yesterday. And I think it was incredible when I saw this study. So how are doctors in the United States treating patients? This is data in over 1 million people. So this is 2005 going to 2016. And in green is metformin. So somewhere around 60 to 70% of patients are being treated with metformin therapy. Good. And if you look here, second is, this is when you work on the Mac. Here you have insulin, and next is sulfonylureas. So metformin is the #1 drug prescribed in the United States. So what happened if you fail to metformin? Which agent do you use? And here you have 60%, whereas in 2005, sulfonylurea is still the number 2 drugs after metformin. The same thing at the Emory system. And second drug is DPP-4. And we're going to discuss today, this is a $5 medication, this is a $400 medication, but this produces hypoglycemia and this does not. So we need to make a decision, and it has to be individualized per case.
Okay, so this second case is an elderly patient with long-standing type 2 diabetes. Again, hypertensive with dyslipidemia, well controlled, does not have known coronary disease, essentially normal renal function for age. She lives by herself. She eats 1 large meal per day. She doesn't test her blood sugars at home because of visual issues, and she's been on maximum dose metformin therapy with an A1C above target. So basically similar patient except for elderly and potentially at risk for hypoglycemia. So the American Diabetes Association in this patient would say the A1C target may be able to be liberalized in this patient because she is at risk for hypoglycemia. She has long duration of diabetes, shorter life expectancy, and relatively limited resources from that standpoint. So this is a patient you may not be aiming for less than 7 or less than 6.5, and a patient where you'd probably want to avoid agents associated with hypoglycemia risk. We know hypoglycemia is significant, and costly and can result in hospitalizations. This is some data from a couple years ago looking at over time, we've done a better job in elderly patients of decreasing their likelihood of being hospitalized with hyperglycemia. But as we've done that, the hospitalization rate for hypoglycemic episodes has actually increased. We know that severe hypoglycemia is a cardiovascular risk factor, and this is a composite slide showing that severe hypoglycemia within the realm of a cardiovascular outcomes trial here is associated with increased cardiovascular events and increased cardiovascular mortality specifically. So avoiding hypoglycemia in high-risk patients is very important. What are we going to avoid in this patient? Well, long-acting second-generation sulfonylureas, would be associated with hypoglycemia risk. Of the 3 second-generation agents, glyburide is the one that's associated with the highest risk of hypoglycemia compared to glipizide or glimepiride. And elderly patients, those with renal impairment and poor nutritional status, are the ones that are at risk. The shorter-acting meglitinides, insulin secretagogues, like repaglinide and neteglinide, have lower risk of hypoglycemia than longer-acting second-generation sulfonylureas. So a better choice if you do need something to try to augment or address postprandial hyperglycemia in this class. And they can be taken just with larger meals or individual meals. And then insulin, we know, of course, carries a risk of hypoglycemia. The GLP-1 receptor agonists, which are dosed, these are subcutaneous medications. Byetta is a twice-daily injection. Victoza and Adlictin are once-daily injections. And then Bidurion and Trulicity are now once-weekly preparations of GLP-1 receptor agonists. These are attractive medications for a variety of reasons. They don't cause hypoglycemia as monotherapy. They have a central effect in the brain in suppressing appetite, so they're associated with weight loss in most patients. They're effective, lowering A1C on average by up to 1.5 percentage points. The only downsides of these are their shots as opposed to pills. They're on the more costly side, and they can be associated with significant problems with nausea by slowing gastric emptying. SGLT2 inhibitors are oral medications that are promoting glycosuria by interacting with the sodium glucose transporter in the renal tubule. These are the medicines that end in flozin. There's 3 of them. They're oral and once daily. They don't cause hypoglycemia as monotherapy. Because you're spilling glucose in the urine, they can be associated with weight loss. They're pills. And we'll hear more at the end of the trial about the potential cardiovascular benefits of this class of medications. Downside is they're not quite as potent as some of the other agents in glucose lowering. They're expensive. Because you're spilling glucose in the urine, there's higher rates of bladder infections and yeast infections, particularly in women. They can be associated with rare cases of spontaneous diabetic ketoacidosis, even in type 2s. And there's some concern about potential increased risk of amputation with one particular agent that was seen in a big clinical outcomes trial. How about the DPP-4 inhibitors? These are oral agents that are trying to augment the action of incretins endogenously. So they end in gliptin, sitagliptin, saxagliptin, and linagliptin. Don't cause hypoglycemia as monotherapy. Well tolerated. Pills. And essentially weight neutral. Disadvantage is they're not as potent as some of the other agents in lowering glucose, and they are on the expensive side. Then there's the TZD pioglitazone. This is an agent that's improving insulin action specifically at fat cells. Doesn't cause hypoglycemia as monotherapy or with metformin. About a 1 to 1.5% A1C reduction, once daily, and generic. Downsides are potential for increases in weight, definite problems with fluid retention, and spontaneous episodes of CHF in certain patients. There's some data to suggest that they may be associated with increased fracture risk and concern about long-term bladder safety and bladder cancer with long-term high-dose use. So what do we do in this patient? Again, we have options. We're going to be favoring the agents not associated with hypoglycemia. I personally would be having a talk with this patient about what their financial resources and insurance resources were and deciding between the generic option versus the branded or more expensive option. If they had good insurance and knowing that my A1C target's going to be not as tight in this patient, probably would suggest a DPP-4 inhibitor as second-line therapy. If she doesn't get to goal with that, then adding a third agent.
So I'm sure that some of you are saying, gee, do I remember all of these names? We're just going to go and make it more simple at the end, I promise you. But it's just where we are right now in diabetes care. But I work at Grady off and on for the last 30 years. And I have 34% of our patients have no insurance. So what do you do with them? You have a 48 landscaper who's married, have 3 children, so tough financial situation, has diabetes, have no insurance, and is managed with metformin therapy as a single therapy. He's on ACE, no history of cardiovascular disease. He's 28, so he's overweight. Vital signs are normal, laboratory is normal, and no insurance. His hemoglobin A1C is 8.5. So what is the next step? So again, let me go back to this Emory algorithm. So you have here sulfonylureas and pioglitazone together with metformin, and you can spend $10 to $15 a month combining the 3. If GLP-1, I'm going to have more data on cost, but the rest is going to be somewhere between $250 to $600 per medication. And there is no data comparing metformin, sulfonylureas, TZDs with the others, but the reduction of hemoglobin A1C is going to be about the same. What you're going to have is different side effects. So, but if you look for a cheap way to treat patients, you have metformin that comes in extended release. That is my preferred way to treat people, 1 tablet a day instead of 2 tablets. Or you can do the short-acting, what most doctors do, metformin twice a day. Perfect. But you can give metformin, and it costs somewhere around $5, $4 in most of the pharmacies. You can use sulfonylureas. And you have here glipizide. It can be short-acting or long-acting. This is one of my preferred agents, or glimepiride. I left glyburide, and I think glyburide should never be prescribed for diabetes care because of the higher risk of hypoglycemia, especially in the elderly. But these agents work well, and you can titrate up your medications. And you have pioglitazone, that the dose goes from 15 actos. 1 out of 3 patients in the United States 15 years ago was on this medicine. Now 4%, because of the high risk associated weight gain and side effects. So you have somebody that is no insurance. You have medication that you can treat them with $2 to $5 per day. While the others are a little more expensive, a lot more expensive. So there is no reason not to maximize diabetes care due to the lack of medication. And this is about the cost for those who like graph instead of tables. If you have medication that the cost is less than $10 and medications who are quite expensive. So it's up to you, it's the patient, but again, it's not that I don't prescribe the others. I mean, I'd love in an elderly person with hypoglycemia switch them to metformin, DPP-4, sitagliptin, linagliptin, saxagliptin. It works very well. But their cost may be prohibited for some of these patients.
So the next case is going to illustrate the challenges in managing type 2 diabetes in the setting of renal disease. This is a lady who was well controlled on metformin monotherapy, had normal renal function, and is admitted to the hospital with acute kidney injury, hypotension, and sepsis. She's treated successfully, and her creatinine comes down, but not to baseline. They held her metformin appropriately while she's in the hospital, treated her with sliding scale Novolog while she was there. At the time of discharge, creatinine's down to 2.3, GFR is less than 30, and her A1C is now 8%. What are we going to do with her? Well, metformin's our friend in most situations, but not here. In the past, I think many of you were familiar with the contraindications to the use of metformin, saying don't use it if your creatinine is greater than 1.4 in a woman or 1.5 in a man, but recognize that these recommendations have been updated. They were initially designed to try to minimize or prevent use of metformin in patients at risk for lactic acidosis. We've got more data now to say that lactic acidosis is a pretty rare complication even in patients with moderate renal insufficiency. So they've liberalized a bit the recommendations on use of metformin in patients with renal insufficiency. They recommend not using serum creatinine, but eGFR is a better indicator of renal function, particularly in older individuals or patients with decreased muscle mass. Still recommend not starting or initiating metformin if your eGFR is less than 45. But if you're already on it and your eGFR is between 30 and 45, they say it's okay to continue metformin, but adjust the dose toward the moderate level rather than the maximum level. If the eGFR goes below 30, you're obliged to discontinue the medication, and you should be assessing their renal function at least once a year, more frequently in people that may be more at risk for renal insufficiency. This is good. We can use it in more patients than we used to be able to. This is a summary slide looking at the profiles of all of these various anti-diabetic medications used in different clinical scenarios. And you can see here, orange is bad, yellow is caution, and blue is good. In the renal line here, you say, obviously, metformin in this patient with the GFR of less than 30 is out. The GLP-1 receptor antagonists, exenatide or Byetta, specifically in the package insert, says it's contraindicated if your eGFR is less than 30. The other GLP-1 agonists say use this with caution in patients with moderate decreased renal function, eGFR of less than 45, because primarily the fact that you'll see more in the way of negative GI side effects and more potential for dehydration in that situation. So GLP-1s we're going to have limited use in this patient population with renal insufficiency. The SGLT2 inhibitors don't work in interacting with the sodium glucose transporter in the kidney if GFR is less than 45, so they're not expected to be effective in that population. And the predilection for bladder infections is not attractive in that population as well. You can still use sulfonylureas, meglitinides, and insulin in patients with renal insufficiency, but you need to recognize that the risk of hypoglycemia is going to be higher in that population. So what are we left with? We are left with the DPP-4 inhibitors. They can be used in patients with renal disease. 2 of them need dose adjustments, not because of concern about side effects or toxicity, but because you get the same therapeutic lowering of glucose at a lower dose if they have renal insufficiency. You can use pioglitazone in the setting of renal insufficiency, but need to be careful to watch for the volume issues of fluid retention in that population. And as I said, hypoglycemia is going to be more of a concern if you're using insulin secretagogues or insulin in this population.
So the next case is somebody that, same patient or similar patient that the first one that presented with 1 drug, needs combination drugs now. This is a lady that has 12-year history of diabetes and is already on 2 drugs. Or it can be in 3 drugs, and metformin, glipizide, sitagliptin. This is a DPP-4 once a day. And you send it to education, you cancel on weight loss. Unfortunately, didn't lose too much weight. BMI is 31. Blood sugar is average about 200, and the hemoglobin A1C is 9.1. This is about 1/3 of the patients that we see in the clinic. So what do you do when somebody is on 2 or 3 drugs? So the current recommendation, if you go from, and this is important, let me just back off 1 slide. If you have 2 drugs and you add a 3rd oral agent, the reduction of hemoglobin A1C is no more than 0.5, 0.6%. So you have somebody on 9.1, 2 drugs, you add a 3rd one, $400, it's going to get 0.5%, you're still above goals. If you have 3 drugs, if you have a 4 drugs, it's less than 0.5% reduction of hemoglobin A1C. So the bottom line is that you have to go to insulin. So these are the current recommendations for the last 30 years. You start with 1 drug, you never substitute your add-on, remember this, you have 2 or 3 drugs, and if not a goal, you add insulin. So what is the insulin that we need to do? There are 14 different types of insulin formulations. So we want something that is called basal insulin, an insulin that is going to work throughout the day, improving glycemic control. So there are human insulin, the NPH that all of you use or have used in the past, available since the 1950s. You have the insulin analogs during the last 10 to 14 years. You have the Glargine, the Lantus, the Detemir, and the biosimilars now. And now we have a new set of insulin that we call it Ultralon. So 14 different formulations. So which is the one that you have to use? It doesn't really matter. So let me go back and walk you through how you start insulin, how you improve insulin therapy. So you're going to start the insulin once a day. If you give NPH, always at night. If you use Glargine, Detemir, or the Ultralon, can be given at any time. And the reason why you give the NPH at bedtime is because it has a peak. So we wanted the peak to be somewhere around when the patient is ready to eat breakfast. So if the hemoglobin A1C is less than 8, we start on 0.1, 0.2 units per kilo. So somebody like me, you start in 15, 16 units of insulin. And you don't stop the oral agents. You add on to the oral agents. If the patient is taking sulfonylureas, you have to decide the risk of hypoglycemia. If the hemoglobin A1C is greater than 8, so this patient is 9.1, is 90 kilos, and we start this patient somewhere around 18 to 20 units of insulin. So how good is 10 to 20 units for somebody with a BMI of 30? Well, not very good, that's right. So you need to intensify. Again, here's the dose, 0.1, 0.2. Glargine is the same, just with the time of the day may be different. And you have to increase the dose. And what we tell the patients, and we write in a piece of paper, is you increase by 2 units every 3 days, every 5 days, until your fasting blood glucose is below the number that you want, usually 140, 130, 150, whatever you want. If the hemoglobin A1C is greater than 80, as it's 200, 200, you can increase by 4 units. The most important thing is 10 units for the right leg. You need more than that. The average insulin requirement is somewhere around 40 units in a patient with diabetes on top of the oral agents. So the second question is, should I use the cheap one or the most expensive one? That's right. Which is better? So NPH 1950, Glargine year 2000. So this is the reduction of hemoglobin A1C in a study that is called Treat to Target. There is no difference in the reduction of hemoglobin A1C. But if you have an insulin that you give at night and peaks at 3 in the morning, you get more hypoglycemia. So, but not everybody develops hypoglycemia. So if somebody is taking NPH 7030, develop hypoglycemia, this is a great option. Switch them to a more stable, no-peak insulin injections. So now we have all of these new insulin, that's right. I don't think primary care is using them much, but we have Glargine, U300, Degludec, very expensive medications. So if you would say, is this U300, is this Degludec better than the Glargine that we have used for 14 years? This is the changes in hemoglobin A1C, absolutely no change. But similar what you saw between the Glargine and the NPH, these longer-acting insulin, because they are more flat, or the flatter effect, have less hypoglycemia. So the current way, I think, is to have 2 or 3 drugs. You start insulin. You can choose whatever you want. If the patient is at risk of hypoglycemia, use these more longer, more flat effects according to whatever the insurance company will allow you to use. If you compare basal insulin versus analog versus NPH, similar efficacy, lower risk of hypoglycemia with analogs, and the new insulin have lower risk of hypoglycemia. But I also want to caution you on the cost. So you can buy NPH 7030 by $25 to $100 if you use whatever, depending where you go. Or you can have insulin that costs somewhere between $200 to $400. The most important thing, our message is that start insulin when somebody's not at goal with 2 or 3 agents, and you can choose the patients. It doesn't have insurance to use the Lantus, the number 1 prescribed insulin. Just send them to Walmart, where they cost $24.88. It doesn't matter. You don't need prescription. The patient can get the refill. If you use, it's only coming from vials. That is a problem in the way that pens are much easier to use, less problems. And it works very well. So it gives you the assurance that you can manage these patients in the best way.
So I think that many of you primary care physicians that are treating patients with diabetes have become comfortable with initiating basal insulin therapy in patients that are failing 3 orals or 2 orals, Lantus, Levemir, NPH, you name it. And it certainly is an effective way of getting the A1C down initially. But unfortunately, it doesn't last forever. And I think one of the most common situations where we have patients referred to us is when the basal insulin has been titrated appropriately. The fasting blood sugar is now where it needs to be, here averaging 98, but the hemoglobin A1C is still high. And the problem there is uncontrolled postprandial hyperglycemia. So what do you do in that situation? Going up further on Lantus is just going to cause hypoglycemia overnight and not fix the problem with postprandial glucose elevations. So what does ACE tell us? Well, if you say you're maxed out on basal insulin and orals, the options would be adding a GLP-1 receptor agonist, which will help with postprandial control, or you need to bite the bullet and begin scheduled mealtime insulin. And this is a slide that says all of these options can be done in different ways. You now have a patient who's used to taking insulin once a day in the evening, usually via pen, so they've gotten over the idea of injectable therapy. If you want to go for physiology, what you're going to do is, say, take rapid-acting insulin with all 3 meals of the day. So you're going from 1 shot a day to 4 shots a day. And many patients, their eyebrows will go up and say, I'm not sure I like that idea. There's a strategy that's been proposed and actually works fairly well called Basal Plus. And that's saying, instead of saying take rapid-acting insulin with each of the meals, pick your largest meal of the day and take a scheduled dose of rapid-acting insulin with that largest meal. How do we start a rapid-acting insulin in that case? How many units do we give? The recommendations here from ACE are saying look at your basal insulin dose and take 10% of that with the largest meal of the day. If you don't want to do the math, start with 5 units, recognizing that some patients may need more than 5 units. If their sugars aren't coming down with 1 shot a day, you can move it to the 2 biggest meals of the day. And if that's not working, then you can progress them to what we would consider basal bolus or intensive insulin therapy. Does this work? Yes, it does. This is data from several years ago looking at the Basal Plus approach, again, starting with largest meal of the day and then intensifying if sugars aren't coming down. What do we see? Whether you're taking mealtime insulin once a day with the largest meal, twice a day with the 2 biggest meals, or 3 times a day, A1C reductions are quite similar. So you don't have to necessarily sell patients on 4 shots a day to have an impact in lowering blood sugars. The importance is do something and do enough to have an impact on addressing postprandial hyperglycemia in this setting. Now, what about, I mentioned adding a GLP-1 agonist to the basal insulin as an alternative to doing mealtime insulin. And this is a more recent study in diabetes care that looks at the option of adding GLP-1 agonist, in this case lixisenatide, which is a once daily injectable incretin, versus doing Basal Plus or 4 shots a day basal bolus therapy in similar patients. These are just like our patients, somebody with uncontrolled diabetes on basal insulin and 1 to 3 oral medications. They took them all. They actually had a run-in period where they intensified their basal insulin, and that had an impact on lowering their blood sugars and their A1C. And then they were randomized either to once daily lixisenatide with the biggest meal, rapid-acting glulisine, which is a Pedro with the largest meal of the day, or glulisine with all 3 meals, and they followed them over a 6-month period. What you can see is all of these strategies are effective. The most effective in lowering A1C is basal bolus, 4 shots a day, because it's the most physiologic. Second most effective is Basal Plus, and third most effective is adding the GLP-1 agonist. There are some differences in this population in terms of what happens with weight. Not surprisingly, adding basal bolus insulin or adding mealtime insulin tends to be associated with small increases in weight, whereas adding the GLP-1 agonist is associated with decreases in weight. And if you look here at testing blood sugars before and 2 hours after each of the meals, all of the strategies are effective. Again, the most effective in addressing postprandial hyperglycemia is the most physiologic, which is 4 shots a day basal bolus insulin. But you have an impact in patients who say, I don't want to do 4 shots, by trying that once daily rapid-acting insulin with the largest meal of the day.
So we both talk about insulin, that's right. And let me just give you one comment that I forgot to mention. So if you have somebody taking 2 agents, you're going to start insulin. Already said you can start basal insulin, low dose, and you build on. If the patient has hypoglycemia, you prefer the more stable, longer-acting insulin. But if you have a patient that is not responding, you go to basal bolus. The number 1 side effect is weight gain. And the number 2 complaint is that, doctor, too many shots a day. And in those patients, as Patrick mentioned, instead of going from basal to basal bolus 4 injections a day, weight gain, you can give basal bolus with a GLP-1. Many of us, you can give Liraglutide once a day, exenatide once a week, Liraglutide once a week, and it has the same glucose control, similar glucose control, with no weight gain. So if I ask you, you want 4 shots or 1 shot a day plus once a week, you know the answer. So let me go to the most incredible area during the last 2 years of controversies or new innovative knowledge on management of diabetes. That is the cardiovascular aspect. We know that 80% of patients with diabetes will die of atherosclerotic complication, so stroke, heart attack, peripheral vascular disease. So this is a 68-year-old male, long-standing history of diabetes, treated with hyperlipidemia, hypertension, very well controlled, metformin, and the patient is admitted with non-stable angina. He got angioplasty, got stent placement, and now you have a patient with high risk of cardiovascular event, has an acute MI, so you know that he has 50% chances to develop a second MI during the next 3 to 5 years. So what do? The hemoglobin A1C is 8.1. There are several studies, and there are 3 large studies, all of them somewhere between 3,000 to 10,000 patients, that look at if you maximize glucose control, can you prevent heart attacks or cardiovascular complications? And the answer is no. So this is an advanced trial, 10,000 patients, studies done mostly in Australia, New Zealand, and Canada. No difference in glucose control. Here's the VADT, Veterans Diabetes Trial, 3,800 patients, no difference in glucose control. And the ACCORD, a multi-center studies in the United States, 10,000 patients, that they tried to achieve glucose less than 6.5, less than 6%. And because of the high risk of hypoglycemia listed down here, the ACCORD trial shows that you even increase mortality. So if you push glucose to reduce cardiovascular events, you're going to fail. So the evidence so far says lowering hemoglobin A1C is the best way to prevent microvascular complications, the eye, the kidney, the legs complications. But for cardiovascular complications, glucose is not the way to go. And now we have several trials, but we have 2 sets of agents, or 2 classes of agents, that are shown to have beneficial effects on cardiovascular outcome. One is the GLP-1 receptor agonist, the Liraglutide. There is a trial that is called LEADER, and I've already recommended for approval by the FDA. Semaglutide will be in the market next year. Both show reduction of cardiovascular events. And they have 2 of the SGLT2, the Empagliflozin, Canagliflozin, also shown reduction on cardiovascular disease. So I'm just going to show a couple of slides on these trials because we want to have enough time for questions and comments from you. So this is Liraglutide. About close to 10,000 patients. There were multiple medications, not in control. 75% has cardiovascular disease or very high risk of cardiovascular disease. And they randomized these patients to Liraglutide, a once-a-day medication, a GLP-1 versus placebo. And you have the primary outcome was a MACE, so cardiovascular death, non-fatal MI, and fatal stroke. And compared to placebo, this Liraglutide reduced the risk of these events by 13% on the 3 years, 4 years average of this study, and the reduced cardiovascular death by 22%. The semaglutide, a different agent with or GLP-1, shows similar improvement in cardiovascular events. So what about the SGLT2s? This is a medication that is an inhibitor of glucose and sodium transport in the kidney. It produces glycosuria and nitrosuria, natriuretic, so it's an osmotic event. It's an osmotic diuresis. And you have here that these patients were randomized to Empagliflozin, a once-a-day medication, and they look for cardiovascular death, MI, and stroke. Compared to placebo, these agents reduce the risk of MACE by 14%, and more important, or equally important, significantly reduce the risk of death, of cardiovascular death, by 32%, and because it has a natriuretic effect, it reduced significantly the risk of hospitalization for heart failures. We at Grady are participating in 3 of these 2 investigator-initiated studies to look at the effects of these agents on heart failures and also in the pharmaceutical studies long term. Because of the beneficial effects of these 2 agents, the GLP-1 and the SGLT2, I'm a member of the ADA, the committee who writes the guidelines. This is what we're going to recommend to you in the month of January next year. The graph is going to be different, but the message is the same. We want you to start on monotherapy, metformin. If you are not in control in 3 months, what we used to tell is to go to the bottom. That's right. Just choose among all the agents. Now we want you to ask one question. As my patient has atherosclerotic cardiovascular disease, stroke, heart attack, significant peripheral vascular disease, and they're going, if this patient has cardiovascular disease, especially coronary heart disease, heart failure, we would like you to consider SGLT2 or GLP-1 as a second-line agent. We recognize they're more expensive, there are new side effects, there are new drugs, we are learning about them, but the beneficial effects has been proven in 4 different clinical trials. So we understand that we took the chance to say how many cases we're going to present, and it gave enough time, in addition that we start 5 minutes later for question and answers. So I think that what we would like to say to you is that diabetes is a progressive disease. And you start with 1 drug. You're going to require 2 and 3 drugs. Please don't stay on the oral agents. Choose whatever you want, but move on if you're not a goal. The second thing is safety. If you're having somebody that you have put on sulfonylureas and the patient is having hypoglycemia, don't cut the dose. Stop it. Move to a different agent, because hypoglycemia, as Patrick shows, is associated with increased risk of death. We don't know if the hypoglycemia killed the patient or those who develop hypoglycemia are more prone to have more sick and more death. But nevertheless, the message is very clear. You have 12 different agents that you can choose. And the third thing is move to insulin. So in the diabetes consult, we asked our primary care physicians, some of them, what is the main barrier to start insulin? It's the lack of support. So if you are 3 o'clock in the afternoon, you are behind, they have this patient with 320 and requires insulin therapy, bring it next time. So now we are doing a train-to-training programs to try to educate and provide primary care physicians in the system with trained nurses assistant in the administration of insulin in diabetes control. There are 31 million Americans with diabetes, and there are only 18,000 certified diabetes educators. And we only have 3 in the system here at Emory. So we need to provide and educate both primary care providers and providers in general, physicians, nurses. So I'm the chairman of the national chairman of ACE for primary care diabetes education. And we have put together the first primary care diabetes for academic primary care providers for you guys. The registration is free. I know we dumped you a lot of information. This is going to be from 8 a.m. to 1 p.m. It will provide breakfast, and you don't have to pay. And we have invited nationally recognized people, and Patrick is going to be there. We're going to provide you with good educations about diabetes. So I think we did well, and we have 8 minutes for questions and answers. So thank you very much. Yeah.
Thank you for the great presentation. If this is a progressive, as you say, it's a progressive disease with beta cell decline, is there any role for earlier institution of a low level of long-acting insulin to change that decline? So in a relatively healthy 45-year-old, rather than waiting until they fail 3 drugs, should we consider metformin and a low dose of long-acting insulin right from the beginning?
Yeah. So there's a trial that is called Origin that gave exactly asked the same question. Get somebody with early diabetes, if I give you a low-dose insulin, can I prevent the beta cells to get damaged and you will do just well with your single agents? And the answer, unfortunately, was no. So insulin does not prevent, it's the best agent that we have to bring the blood glucose down, but it doesn't prevent the apoptosis, the beta cell failure. What we know is that if you have somebody coming to you with hemoglobin A1C that is quite high, you can combine medication from the beginning. And it appears that the combination of medication from the beginning have a better long-term glucose control and may prevent the need for a third agent of insulin therapy. Would you like to add something?
Sure. Only I would say if you're not talking necessarily about insulin, I think it makes more physiologic sense to try to use agents like DPP-4 inhibitors and GLP-1 agonists early in the course of progression of diabetes for the reason you're talking about. I think the challenge we face, and I think one of the biggest problems with looking at these algorithms versus real-time practice, is it's hard sometimes to get those approved in patients that haven't already failed cheaper agents like sulfonylureas, which are probably the least attractive physiologically in people who already have beta cell dysfunction. So trying to match the formulary issues with the national recommendations of algorithms, I think, is important.
And cost is an issue. I think Emory spends about $8 million per year on diabetes medication. Any other questions or comments? We thought there were going to be tons of questions.
Hi, thank you. A few years back, there was a lot of intrigue over which drugs depleted the beta cell population more rapidly. Sulfonylureas were bad. Metformin was neutral. The TZDs may have been positive. What happened with all of that?
So metformin is neutral. Sulfonylureas appears to be neutral, and TZDs appear to be neutral. So the story started the sulfonylureas, and it is a war between the pharmaceutical companies suggesting that the beta cells, because sulfonylureas increase the insulin secretion, the work of the pancreas, they're going to get exhausted more rapidly. That never happened to be true. And the United Kingdom prospective diabetes studies, 3,500 patients followed now for 20 years, showed that the decline of beta cells is similar with metformin and similar with sulfonylureas. The TZDs work on decreasing insulin resistance, so free the pancreas, and not much work because they don't have to make that much insulin. And there is some short-term studies suggesting that may prevent the decline, but never had been really true in practice. So I think that the use of sulfonylureas destroying the pancreas is not very well supported in the literature. So in patients who has a condition that is called LADA, some type 1 diabetes, the Japanese has published that they may decrease, but it's not a major concern to me.
So the data with newer agents in coronary artery disease is really obviously important for us to think about. And so we have two challenges. One, we have a lot of patients with coronary disease who are not on those agents that we have to think about switching over, who are under great control. And then the second question is, second part of, I guess, the challenge is given that 80% or so, or 90%, depending on who you read, of patients with diabetes will die of cardiac disease or have cardiac disease during their life. Are we thinking about some primary prevention trials with that could be helpful? My guess is you're involved, right?
So first, let's take the second one. So primary prevention. None of these agents have been shown for primary prevention. The other thing is that for the regular patient with type 2, so no cardiovascular disease, just one of the first two patients that we presented, there is no data that this SGLT2, GLP-1 is going to improve cardiovascular outcome. No data. So that's why the ADA, we decided to keep the same way. If you don't have cardiovascular disease, just keep in the same way we manage the patient because we don't have that evidence. The other question that we get all the time is, should we start this agent much sooner instead of metformin? We don't have that answer. All of these agents were given on top of metformin and other agents. And metformin, although the study was small, the UK PDS, 500 patients, had a cardiovascular protection. So we decided, because of cost, it's $400 versus $5, that keep metformin as the first-line agent. But if you ask me, do I have prescribed in patients with heart failure, recent heart failure, as the first-line agent, this SGLT2? Yeah, sure, I've done it. but it's not really what we're supposed to do. We're supposed to follow the pattern in the West to metformin double agents. For heart failure, how are you going to start these patients? I think that heart failure in the hospital, these are natriuretic, and in the hospital we give a lot of diuretics, so we want them to go home or be in stable hemodynamically condition. And 2 of the trials with Mikhail Kosiboro, we're starting about 3 or 4 weeks after the patient is discharged. There are new trials after 2 weeks when the patient is hemodynamically stable because it may compromise kidney function in some of these people. Let me go, one more thing is that we're learning about these agents. And there is an increased risk of amputations in patients who has peripheral vascular disease, in patients who have previous amputations. The risk of amputation increased by 15 to 20-fold. So we're still learning about them. I mean, we're using them, but I think that it would be very nice to know what's going to happen in the next few years.
Right, and there are ongoing trials looking at their use specifically with cardiovascular outcomes in patients without established coronary disease, right?
And without diabetes.
Right. So, I mean, I think it's interesting from my perspective that over the last couple of years we've tried to make people aware that diabetes in and of itself is a cardiovascular risk equivalent, and that has guided our recommendations on prescribing statins for prevention. And this, I think, is going to be a similar situation once we have more data from populations that don't have diabetes just with established coronary disease.
So I'm going to just interject a word of caution here. So if you go back to whatever it was, your second or third slide that looked at the total cost increase for taking care of diabetics, I mean, you can be sure that the pharma detail folks are making the same argument that, most of these patients are going to have coronary disease. Why not just start them all on, GLP-1 receptor agonists at the beginning or SGLT2 inhibitors? But, can you imagine what the cost impact of that would be nationally? The other point, and, maybe this is a plea for the ADA, it would be, I think, helpful to, kind of promote better understanding, to speak not only in terms of relative risk reduction, but also absolute risk reduction and number needed to treat. So if you look back at those ones with the secondary preventions, what were the absolute risk reductions and the NNTs for those?
So for EMPA, it's about 1 in 70. For CANA, it's about 1 in 150 to prevent one major cardiovascular event.
Right.
For statins, it's about 1 in 28, 27.
Yeah. So when you talk about 30% reduction, the public hears that, and even prescribing physicians hear that. They go, oh, my God, this is huge. So just
I totally agree.
2 cents.
So let me we have no minutes. The message to take home is be aggressive and move on. Don't sit. It takes 8 to 12 years for an American with hemoglobin A1C greater than 8 to be started on insulin. So break the inertia, that's right. And thank you very much.
Absolutely, yeah. In the words of Larry Phillips, do something and do enough. That's what he's taught me. Thank you.